To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for their care of this land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I would also like to take a moment to thank everyone for joining our presentation today. Our speaker this afternoon is Dr. Adrian Baranchuk, who will be presenting on Lyme Carditis, Do I Need to Be Checked? Dr. Baranchuk is a native of Buenos Aires, Argentina, and obtained his medical degree from the University of Buenos Aires in 1990. After qualifying in internal medicine and cardiology in 1995, he completed a clinical fellowship in cardiac electrophysiology in 1997. In 2002, he immigrated to Spain for a research fellow, and in 2003 was appointed as a clinical fellow in electrophysiology at McMaster University. Dr. Baranchuk joined Queen's University in 2006. Dr. Baranchuk is currently professor in the Department of Medicine, Division of Cardiology at Queen's University, with cross appointments in the Department of Biomedical and Molecular Sciences at Queen's University and Department of Medicine at Kingston Health Sciences Center. He also founded the electrophysiology training program at Queen's University in 2007. Dr. Baranchuk is currently the editor-in-chief of the Journal of Electrocardiology and the Journal of the American College of Cardiology in Spanish. He is also the president-elect of the Inter-American Society of Cardiology and is vice president of the International Society of Holter and Non-Invasive Electrocardiology. We will have Dr. Baranchuk present, and then we will open for questions from the audience. You can ask questions by entering your questions into the chat box or raising your hand using the icon. Please help us welcome Dr. Baranchuk to the podium.
Thank you very much, Veronica. I was listening to your amazing presentation thinking, oh, gee, this guy is quite busy. So, and then I realized you were talking about my career. So thank you so much for the opportunity of being presenting to the Lyme Coalition today. And as said by Veronica, please use the chat, or I will try to finish the presentation between 35 and 40 minutes. So we leave a good 20 minutes open for questions. So again, thank you everybody for being here at the lunch hour. I know that some of you are from work. So I truly appreciate this opportunity to share some ideas about Lyme carditis with you and what the lab has been doing in the last few years. So the title allocated for this presentation was Lyme carditis, Do I Need to Be Checked? And the answer is, if you've been suspected of having Lyme disease or you've been confirmed of having Lyme disease, the answer is yes, you need to be checked at least with a physical examination and a 12-lead ECG, which cost is less than $2, takes 5 minutes to do. It's highly reproducible and transmissible in any digital platform. So with that, I have concluded my presentation. I'm kidding. These are my disclosures, but the answer to that question is yes, you need to be checked. And we're going to leave that for further discussion because there are only few studies that systematically have done ECGs in people suspected of having Lyme disease. As you know, I'm a cardiologist, electrophysiologist. I am not an ID doctor, and there is plenty of colleagues here that know about serology, physiopathology, and ID components more than me. So don't ask me those tough questions because I simply do not know the answers. So I'm going to try to cover very rapidly some aspects of the epidemiology, the prevalence and risk factors. I will stop a little bit longer on the stages of Lyme disease to be sure that we agree in which stage there's solid data where the Lyme carditis belongs to this problem. And then I am going to spend most of my presentation on the clinical assessment, diagnosis, and treatment of this condition, as our lab has advanced the guidelines that now are being promoted by the CDC. And then I'm going to touch briefly on two topics because there will be a second presentation later during the month of May by two residents of KGH that will cover our research in those two areas. I don't know to insist a lot on the areas of the world where Lyme disease is quite prevalent. But you all know that in Canada, and particularly in Kingston, we do live in areas where Lyme disease is quite prevalent, and that the summer months are present with a higher presentation. And we do know that you can contract Lyme disease in any time of the year, but certainly May is when we start going into the outdoors, is when the weather gets better, and there is a major risk of exposure. And this is true for many different parts of Canada. And here it is Kingston in the middle of the yellow zone. And you know that we have a great public health officer doing lots of research and supporting research in Lyme, but COVID has taken a part of that attention and resources. So I am very happy to belong to this coalition that will maintain education, creation of policies and research around Lyme disease, even when the world is taking mostly or most of the attention on COVID. And for those from the States and Canadians that are less familiarized with this map, this is the distribution in the States. Now the West Coast is also taken, so there are only few states that are semi-COVID free, but it is a global distributed problem across the states. This up to 2019, the time where the attention and the search moved to basically or most prominently to COVID, how exponentially the reported case increase. Remember that reported case and real cases are two completely different stories. The same thing happened in the States, and you're familiarized with that. A few years ago, I had the opportunity to interact with some cardiologists from Mexico, where Mexico, for a long period of time, was interpreting that their own cases were imported from mostly workers being deported from the States to Mexico or returning from the States to Mexico. But now there is a clear area that we should update this because it has expanded with what we call local or endemic cases. And Mexico is within the list of countries that are reporting in Lyme. So where is the heart in all this? These three stages of Lyme disease, the early localized, the early disseminated, and the late disseminated, are mostly well accepted in the scientific community. And Lyme carditis, or cardiovascular affection of Lyme disease, is mostly located in the early disseminated staging that occurs weeks to months after the infection. And this is why trying to recollect data on changes in your skin, rashes of any kind, or recollection of the backbite sometimes is difficult, because this may occur months prior to the presentation with some evidence of heart involvement. And basically, the two big areas of cardiovascular involvement are the electrical system of the heart, and patients presenting with different degrees of atrioventricular conduction defect. For those that are less familiarized, a shutdown of the electrical system of the heart, or on the other part, a more global involvement of the different layers of the myocardial wall. We call that myocarditis, or even the area that covers the heart that we call the pericardium. So there is something called myopericarditis, and this presentation can be extremely serious and fatal in a matter of days. Unfortunately, we all have cases where, despite of making the diagnosis and starting antibiotic, the patients evolve very poorly and died, or require cardiac transplantation as a consequence of this presentation. And it is important to remember, for the treatment, I will come back later on, but it's important to remember that the classic rash presentation, it's only present in 40% of those people that end up having Lyme carditis. So that direct link of, if my patient did not recollect a tick bite, or that did not present or does not have any evidence of skin lesions, then this is not Lyme. It should be removed. And you will see that I will insist several times on this topic. Now, when we analyze different series of how many people that presented with Lyme disease has a symptomatic manifestation of Lyme carditis, that goes from 4 to 10%. But this is the first tip and warning of this presentation. Some of the cardiac manifestations are asymptomatic. And when they turn symptomatic, they can be fatal in a matter of minutes to hours. So this is why I have answered yes to the title question. Do I need to be checked? Yes. Are we checking every single Lyme disease person to have cardiac involvement? No, because we bought simply that only 4 to 10% have manifestations. So if you don't have manifestation, you don't test. Well, now we learn that even when I'm going to focus my attention in patients that have had symptoms, there's a big bunch of people with evident cardiac manifestations of Lyme carditis that remain asymptomatic, or they turn symptomatic very rapidly, and we may miss those cases. And as I said, for ages, we said that the AV conduction block was what was the major affection of Lyme carditis. And this is here in this area, the intersection of the electrical system between the upper chambers and the lower chambers. Now we have found and published cases where the rotor or motor of the heart electricity, the SA node, is being affected. I will show you a case of that. Or one of the bundles has been affected. And when you have one of the bundles affected, the patient may be completely asymptomatic. And you send this patient home with treatment for Lyme disease, which is way shorter than the proof amount and administration way that you require for antibiotics if you have Lyme carditis. And this is why I'm insisting ECG should be part of the evaluation of every person with Lyme disease. I'm going to illustrate my presentation with 3 cases in total. So far, in all our publications, we've been insisting this is predominantly a disease in young male individuals. So if a young male presents with unexpected conduction disease, think in Lyme. If that person lives in an endemic area and stays in the outdoors, even more. But I will start presenting you an outlier case. It's going to be a female above the 50 years of age, a retired police officer, super fit, running 3 to 5 Ks 3 times a week in the outdoors. She lives in an endemic area, and at the time of the first presentation, she recollects the backbite approximately 2 weeks prior to the initial presentation. She goes to a walking clinic and presents a right shoulder rash that I'm going to show it to you. No treatment given. Come back the next day saying that it was very uncomfortable, and she received some oral cephalexin as this being interpreted as cellulitis. Then 2 weeks later, and after completing the antibiotic treatment, she has right shoulder pain. And finally, 2 days after, where antibiotics were reinitiated, she presents with fever, malaise, headaches, and the ECG shows some degree of conduction, not a very serious one. But this admission was done in our hospital. Someone suspected Lyme carditis, called me, we admitted the patient, and this is the evolution. First of all, I want to show you this triangular rash in her right shoulder. This has nothing to do with the bullseye target. And several times we've been advancing. The typical presentation is only present in 4 of 10 patients. So this is a great example for you to remember that any dermatological presentation in an endemic area in someone that could present with Lyme disease should be suspected for. And this is the ECG presentation. I promise not to be very extensive on that, but these little bumps should be very close to the sharp spikes. And here there is a duplication at least of the time where the upper chamber should be beating with the lower chamber. So there is a delay between the upper and the lower. That is definitely not normal in a previously healthy young individual, and that prompt the suspicion of Lyme disease. Serologists were sent, but they too, as she didn't present with severe symptoms associated with bradycardia, she was only admitted under monitoring. But now you see that the tall spikes are being missed. This is a rapid progression from first degree to second degree AV block. The shutdown of the electricity, despite the patient receiving IV antibiotics, keeps progressing. So this patient is staying in hospital for 12 days until what you see is a recovery of the little bump to the large bump, or the shark spike. And before discharging her, she went on a treadmill where she exercised way beyond her gender and age with absolutely normal conduction. 5 years ago, I have this patient, I could implant a pacemaker, and she has to live with a pacemaker. At the age of 56, you will have at least 3 replacements with 1 to 2% risk of serious infection or dying every time that I need to replace the battery. All that in exchange for 12 days admission. But now, and I will be able to show you some published data, we have for this lady a 1-year follow-up with a completely normal ECG. She's doing her normal life, exercising as usual. The only precaution when she goes to run in the outdoors, she used long socks, all cover, repellent. So she changed her habits based on this experience. This second case is more traditional, 28-year-old male working in the outdoors, lawn care. He also recalled the tick bite. So I'm showing you 2 cases where we've been very lucky. Of course, as we progress, we are improving our interrogation skills. 4 days of fever, chills, palpitation, shortness of breath. When he presents, he has a high degree AV block. When you have a high degree AV block that keeps progressing during the admission, you have to consider doing a temporary pacemaker. During ages, a temporary pacemaker would imply a wire coming through your jugular vein in your neck, and you have to be absolutely still in bed, connected to the generator of impulses. So now I'm talking about a 20-year-old dude that was doing extensive amount of exercise, and from one day to another, he may need to remain 5 days in bed until his conduction system recovers. It was something very difficult to deal with. Well, this case evolved very well. By day 12, we've been able to remove the temporary wire, put him on a treadmill. He was able to run up to 170 beats per minute with no conduction disorders. And I'm going to show you his case and how his case has changed our clinical practice. This is what we call second degree AV block at admission. You see that there is an irregularity because some of the little bumps like this one is not conducting. By day 3, the thing gets much worse, and it is when we put the temporary wire. And you see all those little bumps not conducting to the ventricles. When that happens in a sustained manner and you don't have a pacemaker, you die. But day 12, still he needs to have those little bumps closer to the big spike, but we put him on a treadmill, he did excellent, and he was able to be discharged. But now something was resonating in my mind. How can I change the story while these people is waiting for the antibiotics to work and they are admitted? They are, most of them, young males that were very active, and I have to convince them to stay still in bed for 5 days. This is quite disrupting. So then we came up with a translation of a therapy that was being used for other conditions, which is called a temporary permanent pacemaker. Rather than going through the neck, I go through below the clavicle. We put a true pacemaker wire attached to the heart, so there's no risk of dislodgement if the patient walks. We externalize it, connect to the battery, place the battery on the chest. So to prove this concept, the first case that we've done at KGH, I asked the patient to walk with me from the operation table to the CSU where he was being admitted. So we walked together with that. So ambulation from day one. And that changed our way to approach these young individuals. We put a temporary permanent pacemaker rather than a temporary pacemaker. And that allows avoiding deconditioning of very young and proactive individuals because they improve once they go home before passing the stress test. They can return to work on the very next day. So a few years ago, I showed you this before, we published our first 5 cases. Look at the ages, all male, the older 35 years old. None of them got a permanent pacemaker. And the cool thing I will show you later, now we have long-term follow-up with the longest follow-up of 3.5 years and the shortest 1 year. So the Canadian Medical Association journal, based on that experience, asked us to summarize a paper for practice called 5 Things to Know About Lyme Carditis. So Lyme carditis could be an early manifestation of Lyme disease. When you have a patient that is young, male, presenting with unexpected conduction disorders, think in Lyme. The shutdown of the electricity can evolve very rapidly and can be fatal, so you have to act quickly upon the diagnosis. The early treatment with antibiotics may reverse this condition, avoiding unnecessary pacing with all its complications in very young individuals. So before implanting, and I will insist on that, before implanting a permanent pacemaker, think if that patient could have Lyme. And for that is that we came up with the, I don't want to say the famous SILK score because it was our invention, but I am glad that every month there is 1 or 2 papers being published using the SILK score as the tool to determine if an individual presenting with AV block could be related to Lyme carditis, which is a transient condition. And the SILK score uses a very simple to remember acronym called COSTAR. C for constitutional symptoms. If you present the fever, malaise, joint pain, you get 2 points. O for outdoor activities in endemic areas, you get 1 point. Sex male, you get 1 point. Recollection of tick bite, you get 3 points. Age less than 50, you get 1 point. And if you have a classic rash, you get 4 points. So at the time that we developed this, we had only 5 to 7 cases at KGH. It was too small to validate this score. So what we've done is a sort of statistical trick where we did a retrospective validation. We got 88 cases, 82 or 83 were from the literature, and we asked all those COSTAR questions to a presented case, but those cases we knew they had Lyme carditis. So every time that one of the questions was not reported in the previously published case, we allocated as 0. That was a very conservative approach. And look at this. The sensitivity to determine Lyme carditis was higher than 93%. And this is why we moved the SILK score as a way to recognize patients that are presenting with high degree AV block to determine whether Lyme carditis should be thought or not. And we published our diagnosis and treatment for Lyme carditis in JACC. JACC is the Journal of American College of Cardiology and one of the journals in cardiology with the highest impact factor in the world. It joined me, Cynthia Young, that now she's a PGY2 in internal medicine. At that time, she was a med student in the last year. And I'm going to quickly navigate you through this. Patients present with high degree AV block, we apply the SILK score. And if you have 0 to 2 points, the possibilities of this being Lyme are minimal. So proceed with the standard treatment, in this case, implant a pacemaker. But if you get 3 to 6 or 7 to 12, you have intermediate to high. So order a serology test. Consider if you need or not to put a temporary permanent pacemaker and admit the patient under strict monitoring. Once the patient is admitted, if the patient is asymptomatic with the bradycardia, you can do strict cardiac monitoring while treating the patient with IV antibiotic. If the patient is extremely symptomatic or the bradycardia is extreme, consider putting a temporary permanent pacemaker to allow your patient to ambulate from day one. Now you receive the serology and the serology is negative and the patient is not responding to antibiotics, proceed with a pacemaker. How many patients do I have in that group? 0. But I did have one patient where I gave antibiotics. The patient completely improved, but the serology was negative. So the patient was asking me, are you 100% sure that I have Lyme carditis? And I said, well, I personally am, because I don't believe that Lyme disease is a serology disease. It's a way more complex disease where sometimes the serology is negative. For example, if I took the sample too soon from the primal infection. However, this patient was not comfortable of not knowing exactly why he presented with high degree AV block. He wanted a pacemaker, we implanted a pacemaker. But if the serology is confirmed, continue with the IV antibiotics for 10 to 14 days. And before discharge, once the patient has recovered conduction, we do a stress test. If the patient has not recovered conduction, then you need to put a pacemaker. But as I said, I had 0 cases so far. So if the patient recovered conduction before sending the patient home, we do a stress test. And if you are able to conduct the electricity above 120 beats per minute, I see you again in 4 to 6 weeks with a simple ECG and interrogation to determine if you're doing well. If your conduction starts failing between 90 and 120 beats per minute, I'll send you home anyway, and I'll see you 4 to 6 weeks with another stress test to see if the things improved. How many patients I had in this group? 0. And if your heart rate fails below 90 beats per minute, despite of you having Lyme carditis, I could implant a pacemaker. How many did I have in this group? 0. Why? Because all the patients that were following this sequence, now they are 17, have improved with this scheme, going home and being seen at 4 to 6 weeks, and then at least 1 year of the admission. This was the central illustration. The only thing that I'm going to highlight here is that in our series, more and more the patients require 2, 3, up to 4 visits until someone thought in Lyme disease and Lyme carditis. And that is certainly something that it's still a preoccupation and a trigger for more education. This case was presented a couple of years ago. At that time, Naomi was a med student in the 3rd year. And this is from a different city than Kingston, where a doctor calls me because he had a 23-year-old guy presenting with a shutdown. Look, this is a 6.5 second period where the heart is not beating, but it's not beating the upper chamber and the lower chamber. This is different than what I showed you before, where the upper chamber keeps beating, but the problem is in the lower chamber. And he was asking me, Adrian, I sent this patient home, but now I found this. Should I put a pacemaker ASAP? And I start interrogating on the phone the doctor, and the silk score was extremely high. So I convinced the doctor to bring the patient back to his hospital, take Lyme serology, start antibiotic. At day 5, we get a positive serology for Lyme. He completed 10 days of admission. At day 10, he did this stress test, which is absolutely normal. And this is the 1-year follow-up. So that told us that not only the AV junction can be affected, the motor can be affected. Since then, now we have published the distal conduction cases in the States, in Canada, showing that any part of the conduction system can be affected. And sometimes, as I said before, the patient can be completely asymptomatic. I'm going to move this quickly. We have published with Cynthia again a comparison between Chagas, which is another parasitic tick bite associated disease endemic from Mexico to Argentina. Now we have demonstrated thousands of imported cases in the States and also in Canada. And there's a lot of lessons, as Chagas is known for at least 100 years. There are a lot of lessons that we could learn as investigators from Chagas to be applied to Lyme disease knowledge. And one of the things that we are working is in the characteristics of the long Lyme disease. For that, John Alcott from Johns Hopkins, who is going to be a presenter during this series, is the person with more experience. So we have a paper in evaluation on a systematic review of when Lyme carditis could be transformed into a long Lyme manifestation. And of course, as you hear every day, several times a day, long COVID, as that condition exists, long Lyme also exists and can deteriorate the quality of life of our patients. This is the publication of the young police officer. I have her permission to reproduce her case. She's a lovely individual. And this is a work that is going to be presented by Nancy and Rachel a few weeks from now, but we now have 7 patients follow up for more than 1 year. I think the longest was 3.4 years. The shorter follow-up 1 year with an average of 21 or 24 in the updated paper. This got recently published. The summary is all those patients are doing their normal life, no reinfection, no limitations for physical activity. But the problem is that when the patients do not get recognition for Lyme carditis, they do get a pacemaker. And what is the story of living with a pacemaker? It's not a desirable situation. And having said that, only at KGH, we implant 800 of these devices a year. So we know a lot of what is the life of people living with a pacemaker. When you have a pacemaker, you have a risk of infection that lasts for life. One of your valves where the lead goes through can fail, and that is for life. Increases your risk of aggravating pre-existing cardiac heart failure. It promotes an electrical dyssynchrony. And then you have to replace the battery every 8 to 10 years at a risk, as I said, of 1 to 2% of serious infection. Now think if I implant a pacemaker in a 23-year-old guy, I am going to certainly modify his life, right? So every time that we put a pacemaker, we have to be sure that there is not a reversible condition as Lyme carditis. And this is my last case of the day. 60-year-old man presenting to another hospital with complete heart block. This hospital thought about Lyme carditis, took a serology, and referred the patient to a third hospital to get a pacemaker implanted. Pacemaker implanted with no complications. The serology comes back positive, so hospital 1 calls the patient back and gives 3 weeks of doxycycline. So this doctor treated the patient properly, but the pacemaker was already planted. In November 2020, patient moved to Kingston, comes for his first device interrogation, asking to see me because he read in the news that there was a doctor that was doing cardiology and knew about Lyme carditis. We interrogate the device, and the pacemaker was being used less than 1% of the time, only at night when physiologically the heart rate goes too slow, so the pacemaker picks it up and starts pacing. So it took me about 3 months to repeat all the studies to this guy as if this guy was not having a pacemaker. So what I've done is I turned down all the pacemaker capacities to see how his heart was responding as not having a pacemaker. And what I found is that this person was able to exercise a lot, conducting with absolutely normal electricity. So what do we do now? These are the figures that we get from the pacemaker. What do we do now? So we initiated a long discussion with this patient about the possibility of removing the pacemaker. The surgery to remove the pacemaker within the first year of implant is quite simple. Take us about 15, 20 minutes. And the risks of when we remove the lead from the heart, remember that the lead is screwed into the cardiac wall. So we have to unscrew that and we have to take it out. We have very skilled surgeons doing that at KGH. In this case, Dr. Chaco, one of the cardiac electrophysiologists, did the procedure. It was a well-shared decision between the patient, the family, and us. It was the first time that something like this was going to be done. It has been done with absolute success. As per today, the last control was a few months ago. The patient is doing a completely normal life without a pacemaker. But the interesting story is that a second pacemaker on the same month comes with exactly the same scenario. Another hospital pacemaker, serology positive, antibiotic treatment. So we did in the same month 2 extractions of recently implanted pacemakers. This has been now collated and accepted for publication in JACC, again, very high impact factor by Rachel Wombold, a PGY4 in cardiology, currently on maternity leave and enjoying a new baby. And both Rachel and Nancy will be presenting in detail these results because it's changing the game of how we manage these cases. And we've been able now to design a second new algorithm, which is how to think and manage patients that got implanted with pacemakers where you have a firm diagnosis of acute Lyme carditis. I'm not going to go through this in detail as they too will cover this a few weeks from now. The CDC now has a dedicated page on Lyme carditis. I'm very honored and proud that 2 of our work, the work that we did with Cynthia, is part of the recommended literature. So for the next presentation, these 2 ladies will also cover the aspect of the so-called long Lyme carditis and the results of our investigations. I am very thankful for this opportunity. And if there's questions in the chat or someone wants to unmute, I'm happy to stop sharing and we have time for questions.
Thank you, Dr. Baranchuk, for your engaging presentation today. We do have one question that has popped up. I'm going to read it off to you. Dr. Baranchuk, can you please discuss long-term and progressive non-acute damage to the heart that may be related to long-haul Lyme? Do you distinguish between Lyme carditis and irregular heart rate caused by autonomic malfunction in long-haul Lyme patients? Thank you for your wonderful work, and maybe I have a wait for the next, and I cannot wait for the next presentation.
No, I think that there are 2 questions, in the first question, and I will summarize the first one. So first of all, thank you. I'm not sure who did those questions, but it's somebody that understood this very, very well. So there is something called myopericarditis or myocarditis, which is usually an acute presentation. I spent less time on that because the Lyme acute myocarditis does not differ of any acute myocarditis. You may resolve with proper antibiotic treatment, or you may evolve acutely into cardiac heart failure. And in some of those cases, this may be fatal. You may recollect reading a case in CMAJ. It's not our case, but I've been consulted by a team from their Newfoundland on a 16-year-old girl that unfortunately died on her birthday, awaiting a cardiac transplantation. It's a horrible story, but it's a permanent reminder to me that when you are facing an acute myocarditis in this region, the idea that this could be Lyme disease should be prompt, and serology for Lyme should be part of the other serological tests that we do to see if we can find a reason. Regarding the evolution to chronic cardiac disease, we call this Lyme cardiomyopathy, which is the evolution that could suffer a person that A, did have a myocarditis and was not treated, B, did have a myocarditis but was properly or incompletely treated, 3, did not have Lyme carditis but had Lyme disease and was improperly treated or misdiagnosed, that years from the acute presentation may develop an unexplained dilated cardiomyopathy, which is when the heart dilates, increases in size, and the pumping function is not appropriate. And we know that patients with that condition have a very poor prognosis within 5 years, with about 50% of them dying in the next 5 years after making diagnosis. So there are several anecdotes of those cases, and even series. Some of them are excellent papers. Some of them are weak papers. So what we've done in Queens, in conjunction with the group of John Alcott from Johns Hopkins, is we systematically review all those experiences and came up with a possible model that explained who are the patients at risk of developing this, and eventually what to do if you face this condition. Of course, that cardiologist, when we have a patient with a dilated cardiomyopathy and we don't know the cause, we invented the term idiopathic cardiomyopathy, which in essence means we have no idea why your heart is dilated. Well, what great experience could be to grab the big bunch of idiopathic cardiomyopathies of endemic regions and to all those patients to run serological tests, where it will be divided into a group with negative serology, forget about Lyme, and positive serology. For those patients with positive serology, you could do a randomized control trial of antibiotics versus placebo. So as you can see, and I hope Veronica is taking notes, there's a lot of opportunities to do research in the so-called long Lyme long Lyme disease or Lyme chronic cardiomyopathy. Now, your second question is super interesting, and there are small series. Unfortunately, the longest series from Poland is not very strong on cases of Lyme carditis presenting only with rhythm disturbances, and most specifically with atrial fibrillation. This is a wonderful area to explore, as atrial fibrillation is pandemic. We see thousands of patients a year only at KGH with atrial fibrillation. Is it possible that this is the primo manifestation of a Lyme carditis? I don't know. It's a great question. There is only one paper published in American Journal of Cardiology by a Polish group. The detailed reading of the paper give us a lot of uncertainties whether those patients were having Lyme disease as the trigger of atrial fibrillation, as they were the vast majority above the 65 years of age with either hypertension or coronary artery disease, which are other risk factors for that rhythm disturbance. Thank you for those questions.
Thank you for the question and for the answering it, Dr. Baranchuk. I see that Dr. Salmon has his hand up. I'll pass it over.
Hi, Andrew.
Thanks, Dr. Baranchuk, for such a wonderful presentation. From a practical perspective, you started out it by saying that everybody who has Lyme should get a cardiac, should get a ECG, 12-lead ECG. Now, I see where even after getting the treatment, is it that persons can end up going into electrical disturbance, and so they should have a repeat ECG? And if they're to do a repeat ECG, when would be that time to do that repeat ECG?
Amazing question, Andrew. I think that the interrogation, physical examination, and ECG could allow you to divide three types of patients. Those where the suspicion of Lyme disease, not of Lyme carditis, of Lyme disease is extremely low, and you're not going to treat those patients accordingly. For that group, I don't see the need of ECG follow-up. Then the group where your suspicion of Lyme disease is extremely high and they have a completely normal ECG and lack of symptoms, I don't see the need for ECG follow-up. And then you have the third group where you have Lyme disease and ECG manifestations. If those ECG manifestations are indicating a strong risk of Lyme carditis, those patients should be admitted under cardiac monitoring. And what I'm saying is that some of those disturbances can be completely asymptomatic, but as it happened with the series of kids from Pennsylvania, someone maybe in the audience can help me refreshing the name of this team, but it's something like Lyme Peds or Peds Lyme. It's a group in the US working specifically with kids. When you see the discrimination of the type of ECG disturbances I have no doubts on my mind that I could admit some of those kids for permanent monitoring. Why? Because despite the treatment with antibiotics, some of those kids may progress and you may end up having them back as an emergency. So for those kids, is admission and permanent monitoring. So the ECG is being collected 24/7, right? So for those where you perceive that there is an abnormal ECG manifestation that does not warrant admission, what I could do is certainly I could repeat an ECG at the end of the antibiotic treatment to see if there was modification of that ECG abnormality. If there was none, you may evaluate that case as a pre-existing condition. If they completely resolve, further imaging may be necessary because once there was an ECG manifestation suggesting the possibility of Lyme carditis, those patients should have at least an echocardiogram to be sure that they are not in the 10% people that will present with myopericarditis. These recommendations, though, Andrew, please note that are experience-oriented, and there is a big gap of knowledge on what to do because there is only one single experience in the world on doing systematic ECGs to people presenting with the suspicion of Lyme disease, not of Lyme carditis, of Lyme disease. So there is a lot to learn and improve in the management in this area. Great question.
Thank you both. We still have a few minutes for any additional questions. I don't see any in the chat box or any hands raised. If you do have a question for Dr. Baranchuk, please don't be shy. Go ahead and unmute and ask your question.
I just have a question out of curiosity. You mentioned, if I'm following this right, the Lyme carditis is linked to a tick bite, but you don't always have confirmation of Lyme infection. So in terms of Borrelia infection, I'm wondering if there may be other pathogens, and we know that ticks carry other pathogens, and whether that could also be a cause, or are you pretty confident that it's Borrelia per se?
Rob, thank you. Amazing question, because I think that I only mentioned one of the reasons of having someone presented with the full combo, right? Previously healthy, no cardiovascular history, shutdown of the electricity. I take serology, I start antibiotic treatment. By day 3 to 5, the patient completely improved. I did not put a pacemaker. I put the patient on a treadmill. He's able to exercise up to 170, 180 beats per minute. Everything is perfect. This patient has Lyme carditis. Boom, serology is negative, all right? So, and the case that I was mentioning, this guy could not be convinced that the suspicion for Lyme carditis was extremely high despite of a negative serology. So the one that I mentioned was taking the serology too early in the process and evolution of the condition, thus the patient being treated quite early and then not giving that body time enough to wake up immunology against Borrelia. But the second big one, thank you, Rob, and I didn't mention that, is that you have an alternative to Borrelia, and I did mention Bartonella. Rob, you're taking me out of my zone of comfort, but we do have cases of, not us, but when I say we as the scientific community, of cases of Bartonella presenting exactly the same as Borrelia, but being negative in the serology. So there are more than one cause. Early, different germ, as Rob is suggesting. Bartonella is the one that comes rapid to mind, but I'm sure in this audience, maybe people that will remind others. And immunocompromised patients that are unable to generate antibodies, not even to Borrelia or to anything else. Some of the papers in the literature, and I think that this is interesting, Rob, is the ones that in the past have done cardiac biopsy. That is basically taking a piece of tissue to look not to antibodies, but to look to DNA of the Borrelia. And several patients with negative serology, but with classic evolution, tested positive for a Borrelia DNA in those samples. That is why every time that I have the opportunity, I refresh the memory of the audience. This is not a serological disease. This is a more complex disease where if the patient is presented with a shutdown of the electrical system, running the silk scores through the CoStar can give you a very high probability of that being Lyme disease. And if it does, treat accordingly. And I would like to say, well, my first case of the serology coming negative came in a time where I was still learning. So today I could sit down with the patient and try to write on stone that everything is going to be okay for them, and refreshing the memory that there are other bacteria that we didn't test, that there is a series of reasons why the test could be negative. For example, I didn't repeat to that patient a test, right? I could say, don't get the pacemaker, come back in 4 weeks to see me. We do another serology. If it remains negative, we can rediscuss this. I just put a pacemaker because I couldn't convince the patient. But I think that there's still lots of room. Thanks for this question. That very valuable.
Great presentation. I really enjoyed it.
Thanks, Raul. Appreciate it.
Thank you both. Is there any additional questions for the audience before we wrap up today's presentation? Feel free to unmic and ask your question or comments. Okay, I'm just looking. Oh, go ahead.
All right, I have a question. I'm afraid I don't understand. I have the Lyme neurological problem, so I can't understand thoroughly, you know, the mechanism of the heart and so on. But in my condition, I have long Lyme, have had for years. My Lyme doctor about 3 or 4 years ago noticed a skipped heartbeat.
I lost the sound.
Mary Lee, we seem to have lost your sound right now.
My blood pressure has gotten kind of out of control. Should I be concerned? Is there anything special I should do in future?
Thanks, Mary Lee, for your question. I'm truly sorry that you are experiencing this condition. I do believe that someone that has a firm diagnosis of long-term neurological consequences of Lyme do require a full cardiovascular test. The piece of advice that I pass is, even if we find abnormalities, being 100% sure that those abnormalities are associated with Lyme disease when you are above 65 years of age is extremely difficult. And I do receive lots of referrals every week from the States and from Canada, from different parts of the world, that people that wants to come to my office to discuss this in person, assuming days of not working, transportation, flights, etc., for me to tell them, I don't know. Why? Because when you are above certain age, skipping cardiac beats or having a palpitation or a clog on your chest is very common, even if you have never been exposed to Lyme. So while I could certainly recommend a full cardiovascular evaluation in your case, I would like you to be prepared to listen from your doctors that the link between those findings and Lyme are still uncertain. So I do invite you to attend the session of Dr. John Alcott that is going to be based specifically on the manifestations of the long Lyme. That will give you an open perspective of how much research has advanced in this area. The first systematic review is going to be our work, where in order for us to suspect that your condition is associated with Lyme, you have to have a sort of check mark, right? And that check mark can be done by evaluating your heart a little bit in more deepness. The second part of your question is something that I left unanswered by the first question. I apologize for that, which was, is there a relationship between having a low blood pressure a low heart rate and a long Lyme condition? The answer is yes. And that is something that has been very well studied in the Johns Hopkins University, which is called POTS, postural orthostatic tachycardia syndrome. And this is a condition that can happen due to many other conditions than Lyme, but the profile of patients having POTS due to Lyme is very well described and known. And I am pleased that now there are strategies to treat the POTS associated with Lyme disease, which within other things involve retreatment with antibiotics in the chronic stage.
I'm sorry, I wasn't really clear. The problem is high blood pressure at this point in time.
High blood pressure, I will not reveal your age. I think I know, but I promise not to make it public, okay?
It's
But
okay.
high blood pressure at your age is a very common scenario. Mary Lee, if you talk to your friends, colleagues, or whatever you do in your life and you're surrounded by people of your approximate age, and you ask how many of them are taking pills to control high blood pressure, you will be surprised that between 60 to 75% of them will be taking pills to control blood pressure. So is your blood pressure responsible of a long Lyme condition? I don't think so. I think that as I am developed also my white hair here, the white hair comes also with a higher blood pressure. And I think that we should be very careful before linking classic cardiovascular manifestations to Lyme.
Thank you.
Anytime.
Thank you again for your question, Mary Lee. I'm just going to give you an update as we wrap up today's presentation. You can see, I just have to sort this out. Tomorrow we are back with another presenter. Dr. Baranchuk's colleague, John Alcott from Johns Hopkins, is actually presenting on the topic of Lyme disease and infection-associated chronic disease illnesses. So we do hope that you join us. The presentation starts at noon tomorrow, Eastern Standard Time. Also a reminder to take part in our Lyme challenge, wear green or wear a green face mask, take a photo and share it with us to help spread awareness for Lyme disease. If you don't like to submit your own personal photos and you are artistic, you can create a drawing or a piece of art and submit that. All entries received will be automatically entered into a draw for one of 4 $25 gift cards from Starbucks, and we will do our draw on May 31st following our last presentation, and all entries go to Clydern@gmail.com. And before I forget, for all you Star Wars fans out there, may the 4th be with you for the rest of your day. Dr. Evans put in the chat box yesterday to make sure to pass that along to everybody out there. Again, thank you very much to Dr. Baranchuk for his informative, engaging, and as always, interesting. He does draw the crowds out for today, the presentations, and we hope you join us tomorrow when Dr. Alcott will be presenting. So thank you again. Have a wonderful day. Have a wonderful rest of your week, and take care.
Thanks so much. Bye.